1239. You have that in front of you. You have the submission which is made up of 3 separate documents. Can you confirm that they are true to the best of your knowledge and understanding, and that you wish to stand to the commission?
Yeah.
Now there are 3 parts to the documents that you've submitted. One, the first one, the one in the centre, and it starts at page 1243, is a paper on primary and community care not being a panacea. Can you confirm, because it doesn't say whether you are the author of that?
I wrote it.
Thank you. And secondly, I'd like to begin by looking at the other 2 documents. The first one starting on 1239. And that is an interview with an emergency nurse practitioner. And the document at the end is an anonymised email from an Imperial College Trust employee.
Where's the email?
At the back, the email is at the end of your long document. Can you please explain how and why those 2 documents have come into your possession?
Yeah. Well, I'm the secretary of State Hospital, so we put out an email asking for any evidence that people felt they would be nervous to give directly because they were working and worried. So an emergency nurse practitioner contacted me and said that she'd give evidence, but she wanted to give it anonymously. So I arranged to interview her, and that was the first thing. And then the email was something that came through on our email communications.
Well, did either of those people give you any specific reasons why they felt the need for anonymity?
Both of them said it was more than their jobs were paraphrasing them. Absolutely.
Anne, can you speak up a bit, please?
Sorry. But how's that?
Fine.
Okay.
Could you just repeat that last one?
Yeah, both of them were very clear it was more than their jobs worth.
Now, because these are documents that you've brought in but that you haven't written, are you able to comment on the contents at all?
Well, the email, I haven't had more interaction than that, so that really has to stand by itself. And I took some bits of the email out that might have been able to identify that person. The interview is somebody who I've had long discussions with, and she's authorised me to speak about the interview, so I feel comfortable doing that.
Bearing that in mind, and bearing the context of that, can you assist the Commission with your take on the confusion between urgent care centres and accident and emergency departments?
Yeah, I mean, I should say I have worked as a nurse practitioner, and I have worked in a walk-in centre, and I've been a nurse practitioner in a homeless clinic, so I have some personal experience as well. I think that there is a huge amount of confusion around the differences. I think the evidence is that urgent care centres work best when they're co-located with A&Es. That makes perfect sense then, because you can triage, and if you need more backup, then you've got it in the A&E departments. I think that the fact that the Shaping a Healthier Future plans say there will be A&E departments when they're effectively talking about something that's more like an urgent care is actually quite irresponsible long term. At the moment, there is still no standard for what an urgent care centre does, and I think that makes it quite confusing. And actually, I think there are also internal issues. So, for example, within the document, you'll see that the nurse practitioner reports that in some areas, GP consortiums are urging nurses to turn away, redirect patients who come to urgent care centres back to GP practices because they don't want to sort of pay twice for treatment.
You pause there for a moment. Could you explain a little more carefully what a redirection policy means? if you look at 1241, and it's 3 paragraphs down, that the nurse practitioner says, in KNC, some practices now have a redirection policy, and goes on to explain, but I wonder if you could encapsulate it, as obviously you're...
So what it is if the GPs, I presume, are thinking there's a duplication of resources and they don't want to have to pay price for it. So if one of their patients, what you have to do if you work in that clinic, if a patient comes from one of those practices, you, this is slightly second hand, so I'm not, this is as I understand it, you have to contact the practice and check that there are no appointments possible, that that person will be able to be seen by in an appropriate time. If there are, you're not supposed to treat the person, you're supposed to send them back to the GP practice where they will deal with them. What the emergency nurse practitioner I interviewed talked about was just how time consuming that is, because you're really busy, you've got a room full of really needy people and you're messing about trying to get through to the practice on the phone and then fill in all of the stats and so on. So she said it's very time consuming, it's obviously both annoying, distressing and confusing for the patient.
So can I just be clear about it? Is what you were saying, if a member of the public arrives at an urgent care centre, one of the questions they will be asked is, where are you from, who is your GP?
Not generally, it's only this particular, what I'm saying is that new forms of confusion are happening in little pockets locally, so this is just a small pocket, an area where this particular problem is happening. And at the last scrutiny committee, one of the Conservative councillors in Hammersmith Fulham raised another little idiosyncrasy which complicates things, because he was talking about patients who are not registered GPs being asked to pay at passing through walking centre if they have treatment. I don't know if that's true or not, but he talked about that at the scrutiny committee last Monday. It's just examples of how it's extremely idiosyncratic what goes on still.
So in terms of the urgent care centres, is it the case then that there isn't a consistency of approach? Is that what you're looking at?
Absolutely. I mean, even within urgent care centres, it depends who you're treated by. You might have emergency, in terms of skills. So some emergency nurse practitioners will have extended prescribing, be able to prescribe pretty well anything that a doctor could. Some won't. Some doctors are less confident with trauma and actual accident injuries for medical conditions. So and the fact that staffing is such a big problem, particularly within CLCH, means that a lot of the staffing at the moment is, or quite a high proportion is bank and agency, and again you've got less standardisation then about what skills those people bring in.
Now, just still on the question of urgent care centres, one of the other things that the nurse practitioner says, and this is at 1242, I don't always get the impression services are working together for the patient's best interest. There are turf wars between 111 and the UCC doctors about who should see particular patients. Are you able to explain what's going on here?
I think she was referring to when the urgent care centres are either near the end of a shift, and I think the urgent care, for example, they may want to push the referral over to 111 service, and 111 service don't want to give it to them. I think that's one issue. And just more generally, there are lots of turf wars about whether it's reasonable to ask people to come in to be seen, whether they will do home visits. The guidelines aren't clear, and there's a lot of scope for people who are under pressure trying to pass the buck.
Is there a financial implication involved in who is seen where?
There is, because obviously there's a cost to being seen, there's the cost of the consultation. I don't know if that's the reason or not, I couldn't speak to that.
Can I just ask you very briefly just to have a look at the email, and it is at 1253, and this is the email that we just referred to. And I realise you said that you don't have any background detail, but are you able to help with, without providing identification, what level or type of employee this is from?
That person is an experienced staff nurse who's been in the trust for a number of years.
And her comment, that information that is being fed to the local community is far from reality. Are you able to make any comment on that assertion or not?
I absolutely know that's the case. I know that from my own clinical practice, and I know that from my position in the campaign. And actually, I think it's one of the really big problems of the whole health economy here, that because there's such a pressure on corporate reputations and getting business and looking good, bad news in terms of poor performance or vacancies or whatever is swept under the carpet. So it's really, that's why it's so hard to get a serious debate about what could be improved and what needs to happen.
So is it your evidence to the Commission that you have direct knowledge of wrong or faulty information being promulgated? I'm not talking about falsehoods, but for example, I'm talking about quite selective information. So if you look at, for example, vacancy rates amongst community nursing, which is massively, massively high, I think the community trust would acknowledge that's a problem. I think there's an overall, James Riley, Chief Executive, said last week there was a 17.6 vacancy rate, and they have that as a red risk. But actually, if you dig beyond that, the figures for clinical staff are higher, and for community nursing, they're significantly higher. So that, for example, in Hammersmith and Fulham, amongst trained district nurses, there's a 60% vacancy rate. 60%?
Yes. There's only one district nurse in place for the whole of Hammersmith and Fulham this year. There are 15 community nursing vacancies. And, you know, that broad brush stroke doesn't get down to that kind of level of detail, which is what you need if you're really to assess whether the service is capable of delivering or not.
Can we turn now to your central submission? What your premise appears to be is that the primary care and the out-of-hospital initiatives won't do what Shaping a Healthier Future says they will do. Is that your premise?
It is. I mean, I'm very for primary and community care. It's what I spent my professional life doing and pioneering. And I know of lots of out-of-hospital strategies locally that are really useful and good and probably will deliver something and should be supported. I think the issue is that they haven't been tried and tested. They need to be properly resourced. And unless they're delivered on a much bigger scale, for a much longer time, on a much wider premise, then although they'll be very good and very useful in themselves, they're not going to stop the tide of unplanned admissions and deliver what SAHF wanted to deliver.
So just breaking it down, the current state of out-of-hospital services in the borough is what?
I think there are some very interesting pilot projects going on. I think there are small examples of some positive developments. I think the CIS project, which is a sort of virtual ward type of thing, is potentially very useful.
Can you just tell us what that acronym is? CIS?
Community Independent Service.
Thank you.
But it only lasts for 6 weeks, and it only involves a limited number of patients. And also, what I should say is one of the reasons it will probably deliver good things is because it's well resourced and it's got highly motivated staff. The problem is it then they're not coming from anywhere else except the ordinary pool of community nursing staff. So actually what they do is they often take the most kind of lively people from the bread and butter district nursing service And what they then do, if they work well, is they then generate referrals back to the district nursing service, which has been depleted. So that although you can get these kind of small pockets of very good performance, it's against the backdrop of you've kind of privileged that little service at the expense of the bread and butter stuff.
So is this robbing Peter to pay Paul?
Yeah, yeah.
Now,
Paying Paul.
to what extent do you consider that the relevant clinical commission groups have understood this?
I think there's a really big problem. I think there is that problem about not being able to hear the message, and I think both across Imperial and the CCG and the CLCH, it's such a sort of tough corporate world, and they're so busy trying to get a big enough share of the market to survive and become foundation trust and meet all those targets, that there's lots of reasons why they wouldn't want to necessarily pay great attention to bad news. I think that's one factor. And I also think there's a kind of increasing disconnect really between a leadership and the people, the clinicians on the ground, who, to be honest, mostly now your workload is so high. If you look at, for example, CLCH's vacancy rate I talked about, they've got really high sickness rates. A lot of their sickness is stress. They've got a really high turnover of staff. I know from all the colleagues I used to work with, their workload in terms of number of visits a day is at least double what it used to be, if not more, with more expectations as well. And what that means is a real exhaustion and difficulty engaging on any, you get a medal if you finish the day job, and then trying also to engage with all of this stuff is really difficult. And I think on a more broader level, the King's Fund just put some evidence out about how within the CCGs there's an increasing disengagement between the GPs who are on the face or doing the consultations all the time and the senior leadership, and I think that's a phenomenon we see here as well.
Have you had any conversations with GPs which would underpin the evidence we've just
Yeah, I mean, yesterday. Yeah.
Are you able to give a flavour without giving identifying details?
Well, I was speaking to a GP who I have worked with for a number of years, who rang me up to wish me luck for today, said he wished he could be here, but that he was too worried about the consequences, and he didn't think there was much point because he didn't think things would be able to change. And he's somebody who I have massive respect for as a clinical pioneer.
And is that an isolated conversation
No, not
or something you've heard more than once?
Yeah.
I wanted to ask you just briefly.
Sorry, I should say we have a number of GPs and hospital doctors on consultants. We have a kind of weekly email newsletter that reaches about 500 people, and there's a good, I should say there's about 40 GPs and doctors and consultants on that.
And are they aware of the existence of the Commission?
They are, yeah. No, we've tried hard. There is a real culture of nervousness about getting involved. And I think, partly I think that it feels like we're not some little place in the country where we're taking on a little health board. The hospital trusts here are very, very big. They are, for example, they're very good as well. I wouldn't want to knock Imperial's results, because in many ways they've got the best mortality rates, etc. in the country, so we want to preserve that. But it means it's a huge enterprise. There's the hospital, the NHS Trust, but they've also got the college. They've got really big global ambitions in terms of that, and they've got a lot of research that links up with lots of drug companies. They've got lots of property in the area. So the point I'm trying to make is it's not an insignificant thing to challenge.
Now, just turning to some of the other issues you raised, you mentioned